Welcome to the second day of the Eular, and this session we have on systemic lupus erythematosus. And today is a sort of masterclass on the disease. We have two doyens on the subject who will speak for about 45 minutes each, and we'll try and allow for time for questions between each speaker, but if not, then we'll just push straight ahead. We'll start with Dr. Mary Crow, also known as Peggy, who is the physician-in-chief and chair at the Department of Medicine Hospital for Special Surgery in New York, as well as chief of the Division of Rheumatology at the New York Presbyterian Weill-Cornell Medical School. So, I just hand straight over.
Thank you very much. It's a pleasure to be here presenting in this session. And we can bring up the slides. All right, thank you. All right, well, I've been given the very challenging task of deconvoluting the complexities of SLE. SLE is a very compelling disease for all of us, I think, because of the patients it impacts, but it's also a very stimulating disease in terms of thinking about the complexities of the pathogenesis. We often hear that lupus is so heterogeneous. It presents differently from patient to patient. And in thinking about how I might deconvolute the pathogenesis, what I'm trying to do is to simplify it, to acknowledge that the disease is heterogeneous with all of these different clinical manifestations, but to also hone in on very core mechanisms that we can think about as we think about how we might develop improved therapies for patients. So one of the key features of lupus that adds to its complexity is the female predisposition. And lupus is at the far end of the spectrum in terms of female to male ratio, with really still a mystery in terms of what accounts for that strong female predisposition. And my charge here is to bring up fairly recent observations and ideas about pathogenic mechanisms. So my first example of some new ideas relates to the X chromosome. We've been taught by Hal Schofield's group that the X chromosome dosage is very important. And over the last couple of years, Hal and his colleagues have documented the odds ratio for risk of SLE as well as Sjogren's syndrome that is very much related to the X chromosome dosage. So individuals who are 47XXX have a strong increased risk of the disease. A little later, I'm going to give you some very new data that provides some specific suggestions about why that might be the case. Now, another complexity of lupus relates to its ethnicity skewing. And so we know that the disease is very much more severe in African Americans, with the mortality increased among those in African Americans in the United States study recognized here. And that gets us to the overall complexities of the disease, with environmental factors, access to medication, socioeconomic factors, merging with the genetic risks that still need to be further explored in African Americans. So we all show this very simple picture with environmental factors intersecting with the genetic contributors playing out at the level of the immune system. And I'm not going to spend too much time on the environmental issues in lupus, because I think we have much more work to do there. But I will point to recent data that has been looking at the microbiome. And this is a figure from a recent review article by Greg Silverman that describes a couple of the mechanisms that track back to recent publications. With cross-reactivity to endogenous microbes being one potential mechanism that might lead to autoimmunity, in particular autoantibodies, but then also access of microbes to the host, even with deposition or access of microbes to the liver, driving inflammation, activation of the interferon pathway, and many of the sequelae that link into autoimmunity. But I'm going to spend most of my time taking lessons from the genetic studies that we have benefited from over the last 20 years or so. And I particularly note this very impressive study from Taiwan, where there was access to a very large public database of information from patients enrolled in the National Health Insurance Plan there. And what we can see is that from this study, about 44% of the risk for lupus is due to heritability or genetic factors, with other contributions obviously from genetic factors. And you can see the very, very high relative risk of developing lupus in twins. So clearly a major contribution from genetics and a lot that can be learned. We've had several very impressive studies using the GWAS approach that have been published in the last couple of years. And this one that I'm citing here, led by Karl Langfeld, was the result of study using the so-called immunochip platform. And this Manhattan plot identifies, as many of the studies in autoimmunity do, HLA as being a very, very important factor in the risk for lupus, but other contributions as well. And what was particularly I think instructive from this study, and also encouraging in terms of the potential at some point in time in being able to assess risk in individuals, is that there is this non-additive effect of the genetic load of lupus-associated genetic variants, single nucleotide polymorphisms, that suggests there's almost a threshold. You can accumulate more and more genetic risk variants, but there's a certain point at which point your risk of developing lupus really accelerates. So I think that there could be the potential at some point in time actually having a risk assessment tool that looks at these single nucleotide polymorphisms, basically adds them up and gives a sense of risk for lupus. But with regard to deconvoluting the pathogenesis of lupus, I think what's been most helpful to me and instructive is to take the lessons learned from the genetic studies and identify molecular pathways that those variants are heading us to understand, think about those, study them, and then think in terms of how we could identify therapeutic targets and ultimately new treatments for our patients. So the genetic variants associated with lupus can be bucketed in terms of those that relate to generating antigen, generating apoptotic debris that is out of proportion to what a healthy individual might have access to, but also points to both innate and adaptive immune system mechanisms and pathways that are really key to the pathogenesis of lupus. There's also some information from some of the genetic studies that give us some ideas about why particular target organs might be particularly vulnerable to the altered immune system manifestations associated with lupus. I think less information there. So I've taken those sorts of schemas and simplified for the purpose of this discussion, and really for the purpose of my own efforts thinking about the pathogenesis of lupus. So we can think about how some of those genetic variants, and some of them related to single gene mutations that are particularly rare, and then some others related to more common variants, lead us to think about how self-nucleic acid and its associated proteins and particles might be impaired in their regulation, not handled properly, not degraded properly, not cleared properly, allowing the immune system to have kind of a stimulus to drive it into some of these altered functions that ultimately contribute to autoimmunity and inflammation. But particularly of interest to me in my work over the years in looking at type 1 interferon are the lessons learned from the genetic risk factors, the single nucleotide polymorphisms that lead us to to me, almost undeniable conclusion that type 1 interferon is a very key mediator in many patients with lupus. So it's a very important innate immune system product. But of course, the adaptive immune system and its generation of autoantibodies is essential for lupus pathogenesis as well. We can take the lessons indicated by that very high risk conferred by MHC alleles to think that antigen presentation and T-cell responses are very important, and then think about the B-cell and T-cell, B-cell interactions and how we might learn from some of the genetic risk factors that have been identified there. And then a bit of information on the tissue vulnerability to immune system-mediated injuries. So impaired regulation or clearance of self-nucleic acid, I think, is a very important aspect of lupus pathogenesis. And the most informative lessons, perhaps, have come from the very rare but high-impact deficiencies of some of the classical complement components. So this is the very early complement components that when deficient, and the deficiencies are often caused by targeted single gene mutations, the debris or stimulators that can drive innate immune system activation and adaptive immune system activation are abundant. And we can think about what the mechanisms that link those complement deficiencies to disease might be. And I think most of them fall into what's described in this first bullet, that the complement is required for identification, opsonization, and disposal of apoptotic cells and immune complexes. If that's not working correctly, we have a setup for driving immune system activation and disease. There was a very interesting paper published last year that suggested another potential mechanism in which C1q deficiency was associated with an exaggerated CD8 T-cell response. And so that's a mechanism that can be pursued further to think about. But it's very striking when we look at the impact of these classical complement deficiencies on the clinical manifestations of lupus, just very, very severe form of lupus that's seen in those patients. And I think this tells us that complement, particularly the classical component, is very, very important in our protection from developing lupus. Very interesting study published in the last year brought together the common variants that have been well documented as associated with increased risk of lupus, as well as less common, in fact, very rare variants. And when each parent contributed one of those components, the risk of lupus seemed to be greater. So a small group of Swedish patients were studied, their genetic risk evaluated, and what was notable was that one of the parents contributed ultra-rare mutations in some of the same genes that are very, very important for clearance of immune complexes, regulation or metabolism of DNA, such as these DNases, or signaling downstream from intracellular RNA. So genetic risk of lupus is complicated, but we can learn a lot by the mechanisms that are pointed to by the genetic risk factors. So I'm going to try to be very simple in the way I think about lupus pathogenesis and propose that there are really two key components, and either one alone may not be enough to allow an individual to develop lupus. And those two main components are the interferons, primarily the type 1 interferons, innate immune system products, and autoantibodies. And this may seem very, very obvious, but I think when we think this way, it helps us to both understand targets and think about how we might ultimately test new therapies and do better for our patients. So I'm going to cite a couple of studies that make the point that really we need both of these components. We need interferon, type 1 interferon, we need autoantibodies, and without the two together, the risk of lupus is going to be much, much less than if we have the two together. So a number of years ago, about 10 years ago, I think, we did a study with Jill Bayan. And as you may know, Jill Bayan has done a terrific job of developing a cohort of mothers of babies with neonatal lupus. So virtually all of those mothers have anti-Rho antibody. So the antibody is present. Tim Niewald was in my lab at the time, and we had developed a type 1 interferon activity assay. And what we did was to study samples, serum samples, from the mothers that Jill had collected. So all of the mothers have anti-Rho antibodies, and Tim measured interferon activity in those individuals. So you can see that in our healthy controls, very, very low interferon levels. The mothers who had no clinical symptoms had levels similar to the healthy controls. But those mothers who had either classifiable Sjogren's syndrome or lupus, or some of the manifestations that Jill termed as PAWSI lupus or PAWSI Sjogren's, had much higher levels of type 1 interferon. So both were required to develop clinical manifestations. A very similar message came out in the last year or so in a paper from Ed Vital's group, where he studied ANA positive individuals who he termed at risk for lupus, either based on family history or having one or none manifestations of lupus clinically. And using one of the interferon scores based on interferon-inducible gene expression, he found that those ANA positive individuals who were non-progressors had a much lower interferon score, obviously, than lupus patients or than those that did progress after a year of study. So again, both antibodies, the ANA in this case, and interferon was necessary to develop the disease. And if we look at this issue from the other direction, patients who have cytokines that are elevated, it's only when they add in the autoantibodies that they develop lupus. So you all are probably very well aware of the Arbuckle 2003 study published in the New England Journal using the military samples and showing that autoantibodies are present many years before diagnosis of lupus. Well, the same samples were used to look at cytokines, including interferon alpha, interferon gamma, and others. Those are the dotted lines here. So the cytokines are present a number of years before diagnosis of lupus, but it's only when these autoantibodies come in that the patients were diagnosed. So the message is, in a simplified way, I think very clear. From the first study, anti-Rho antibodies are present, autoantibodies, but only when interferon was also present was disease manifest. And from the military samples, cytokines, including the interferons, were present, but only when the autoantibodies appeared was disease manifest. So I think it's very helpful to think about these two categories of very key mechanisms that are contributing in a very, very important way to development of lupus. So let's talk a little bit more about the innate immune system product, type 1 interferon. Type 1 interferon is really a family of gene products encoded together on human chromosome 9p. And interferon has many, many effects on the immune system. And it has hundreds of genes that it regulates. So they can be categorized into those that are so-called antiviral. They're produced very, very quickly after a cell experiences interaction with type 1 interferon. And then there are a group of transcripts that are regulated by interferon that can be termed immunomodulatory, that might have slightly different regulatory pathways involved in their induction, but can be linked in many ways to altered immune function. So type 1 interferon signals through its specific receptor termed IFNAR and induces these hundreds of interferon-stimulated genes. And the slide describes both the classic pathway signaling through JAK1 and TYK2 and the stats, but there might be some variations in exactly which stats become activated, and those variations might impact specifically what interferon-stimulated genes are induced. The so-called interferon signature now is, it'll be 18 years old, something like that. It was in 2003 that several groups published studies demonstrating this very striking, the red shown here, overexpression of interferon-stimulated genes in the peripheral blood of lupus patients. And this is a study I refer to often because it's so striking. This group collected synovial tissue from patients with lupus, patients with rheumatoid arthritis, and osteoarthritis patients. And the red shows transcripts overexpressed in the tissue, and many of them, those indicated in red here, are type 1 interferon-stimulated gene transcripts. So a clear message that something very much like type 1 interferon or interferon itself is driving broad gene expression patterns, profiles in patients with lupus. So since then, we've understood that the majority of patients with lupus have high expression of interferon-stimulated genes. And in contrast to the situation in a virus infection, where interferon in this blue figure here is made very, very quickly, but then turned off very quickly with its impact lasting in a prolonged way, long enough to take control of a virus. In lupus, interferon is stimulated quite stably in many cases over time. It's persistent and overexpressed with, I think, many, many impacts on the immune system. We are able, though, if we frequently collect blood samples from patients, to find some examples where interferon and the interferon signature very nicely correlates with disease activity. So this is an example of an individual patient with many time points studied here, where you can see the concurrence of interferon score and SLE and BILAG. And then in this very informative and interesting patient who was diagnosed with lupus, but very, very mild lupus with only anti-Rho antibodies being positive, developed a community-acquired pneumonia right about at this time point, and then spiked up the interferon signature with a few months later developing much more severe lupus with a broader spectrum of autoantibodies, and again, a spike of interferon. So we can point to these sorts of examples to implicate type 1 interferon in lupus pathogenesis, and look to the virology literature, the immunology literature to think about, well, what might be the impact of type 1 interferon overexpression over time on immune system function as well as clinical manifestations of disease. And I've just noted here some of the functions that have been demonstrated in publications with regard to interferon's effects, and then think about some of the clinical consequences of those immune system effects that are characteristic of lupus. And I think there are many. So what drives the production of type 1 interferon? This is a question that has engaged many investigators, and it really led to the question, can the innate immune system mistake self-nucleic acid for the presence of infection? Probably the most powerful system that results in production of type 1 interferon in lupus, I think, tracks to the plasmacytoid dendritic cell and the endosomal toll-like receptors, specifically very likely toll-like receptor 7. It is demonstrated from a number of labs now that there can be a number of stimulators that gain access to the endosomal TLR and drive induction of type 1 interferon-induced interferon itself, as well as other pro-inflammatory mediators followed then by induction of that whole panel of hundreds of interferon-stimulated genes. So immune complexes are probably the most logical and powerful stimulators of type 1 interferon expression through the toll-like receptor pathway. But there may be others. Apoptotic cell debris, circulating mitochondrial DNA, nets, components of nets. And we think, though, and in part driven by the observation that the presence of RNA-targeted autoantibodies, that is, those that are specific for RNA-associated proteins, such as anti-Rho or La or SM, RNP, are particularly powerful in driving type 1 interferon. And this graph describes studies in which we isolated immune complexes from patients, lupus patients who either had predominantly anti-DNA antibodies or anti-RNA binding protein antibodies, or both. And it was really those samples that yielded immune complexes enriched in the anti-RNA binding protein antibodies that were very, very active in driving the induction of type 1 interferon. So I think RNA is probably very important, TLR7 is probably very important, and plasmacytoid dendritic cells are important. I briefly mentioned nets, which have become of considerable interest in pathogenesis of lupus. Nets comprise nucleic acid and associated proteins are extruded from neutrophils. And neutrophils themselves can produce some type 1 interferon, but then that material that's extruded from the neutrophils may be able to itself drive interferon production by other cells, but then can also be involved in endothelial cell damage, deposition in tissues, and encourage inflammation. So maybe many, many roles for nets, including induction of type 1 interferon. In recent years, there's been additional interest in different pathways that might be involved in driving type 1 interferon. And that type 1 interferon might incorporate not just interferon alpha, the major interferon, type 1 interferon that we pick up in the blood of lupus patients, but also interferon beta. So these pathways involve cytosolic sensors that are able to recognize or respond to intracellular DNA and RNA. So C-gas is an intracellular recognizer of DNA. DNA protein kinase might be another important mediator in DNA-driven interferon responses. RIG-I and MDA5 are recognizers of RNA. And there might be connections between mitochondrial DNA, particularly oxidized mitochondrial DNA, and the activation of some of these intracellular pathways. So a lot more to study regarding the origins of type 1 interferon in lupus, but I think a very, very important group of mediators, important pathways that might include a number of therapeutic targets. We think a lot about specifically what is the nature of those nucleic acids, and there may be many. I've mentioned the immune complexes that include nucleic acid, mitochondrial DNA, the components of nets. Viruses themselves could be inducers of interferon in a way that would activate lupus or lupus flares. But those intracellular cytosolic nucleic acids, I think, are becoming of great interest, not with a lot of insight as yet into their very specific nature, but we've been very interested in at least considering that some of those nucleic acids might be derived from our own viral-like elements in our DNA, in our genomes, particularly line elements. So line elements are virus-derived ultimately, and can actually encode functional messenger RNAs and protein. We were able to show the protein encoded by the open reading frame 1 of line elements in Sjogren's salivary glands, with also some staining in the tubules of lupus nephritis kidney biopsies. And we showed that if we took a plasmacytoid dendritic cell or a monocyte and transfected in RNA, either with sequence of the U1 RNA that's incorporated into the SNRP particles targeted by anti-SM antibody, or the line 1 RNA that we could induce type 1 interferon. So there might be a link between these genome-derived retroelements and induction of type 1 interferon. So I mentioned that I would get back to the X chromosome with some very recent data and interesting hints that bring together several of these themes. Tim Weiss's group very recently published a very interesting paper identifying a gene encoded on the X chromosome called CX open reading frame 21. This had also been a gene of interest to Hal Schofield's group. And if you look at the Weiss paper, a number of very interesting observations were made regarding this chromosome X open reading frame 21 gene. It escapes X chromosome inactivation. It can be interferon induced, and its expression can be amplified by cell activation. It has higher expression in females, as you might expect, since it escapes X chromosome inactivation. And it co-localizes with TLR7. So these are pictures that involve staining for TLR7, the gene product of CX open reading frame 21, and then the merge where you see co-association of these two compartments, or the TLR7 compartment and this gene product. And in Hal Schofield's paper, he suggested that one of the functions of this X chromosome encoded gene might be to acidify or contribute to the acidification of the endosomal TLR compartments, and he actually showed that the pH of females who express this is lower than that of males. So it may be that this association is very relevant with regard to the impact of this gene, which is polymorphic on TLR7 acidification and function. So what therapeutic targets are suggested by the innate immune system gene association studies, particularly with regard to the interferon pathway? Well, there are probably many, but we can think about targeting the plasmacytoid dendritic cell. We can target interferon itself or its receptor, if NAR, or we can target JAK's downstream JAK pathway components that might be very, very important, or are very, very important in type 1 interferon signaling. Very nice commentary was published recently in association with a JCI description of a phase 1 study of an anti-BDCA2 antibody that targets plasmacytoid dendritic cells. And the figure really describes these different approaches to therapeutically addressing type 1 interferon, targeting the PDC, targeting interferon itself, or the receptor, or the downstream JAK1 TYK2 pathway. So I'm going to move on to the adaptive immune system. And obviously, presentation of antigen is very, very important, but T and B cell function, the thresholds for signaling, some very specific signaling molecules have been pointed to by the genetic association studies that help us to recognize, if we didn't already, the importance of T and B cells in lupus pathogenesis. And I'm just calling out here David Wofsy, our friend, who may have been one of the first to identify T cells as very, very important in murine lupus pathogenesis. This was a study looking at the MRL-LPR mouse in which T cells were depleted with an antibody, and the mice did better. But we've come a long way since then, and we know about many different T cell subpopulations. And I think what's becoming of interest is to think about the relative roles of the T follicular helper cells, which have been of interest for a number of years now because they're so important in driving the germinal centers, the follicles in which antibodies are made. But Th1 cells are also becoming of interest. And each of these T cell populations produces different cytokines. T follicular helper cells make IL-21. Th1 cells make interferon gamma. And it may be that they're both important in lupus pathogenesis. The T follicular helper cells are very important in driving B cells toward differentiation. I mentioned IL-21. They also make IL-4 and some chemokines. They have surface molecules that may be therapeutic targets, including CD40 ligand, the ICOS pathway. But interesting data emerged over the last year or so in the context of the ustekinumab trial that really targets potentially several different T-cell populations. So it targets the P40 component of both IL-23 and IL-12. And at least in phase 2 studies, there was a suggestion that this drug might be effective in lupus. So the fact that IL-12 was targeted, with IL-12 being a very important cytokine for development of Th1 cells, brings some attention to the Th1 cells, and I guess raises the possibility that Th17 cells might be very important as well. So when thinking about B-cell differentiation, there is growing attention in not only considering the germinal center as sort of the nidus of T-cell B-cell interaction and driving B-cell differentiation, but the extrafollicular pathways in which T-cells and B-cells might interact in slightly different ways. And a very recent study pointed to some of the key mediators that might be important in driving B-cell differentiation, and in some context in that extrafollicular context. And I won't go through each of these bullets, but this study pointed to the importance of TLR7, the importance of IL-21 and IL-2, but interestingly pointed to interferon gamma, which perhaps we haven't spoken about so much with regard to lupus pathogenesis. I think the type 1 interferons have kind of dominated the interferon discussion. But this study suggests that interferon gamma might be important in driving certain B-cell populations. You might have heard of so-called ABC B cells, age-associated B cells, that have been implicated in autoantibody production and depend very, very much on TLR7 drivers. So interferon gamma might be an important driver of those cells as well, again, raising possibilities for thinking about additional therapeutic targets. There are single gene mutations that are relevant to B cells as well as the complement pathway that I noted earlier. And some of the variants are rare variants that have been identified in lupus are B cell relevant. Obviously, TYK2 is relevant to the type 1 interferon signaling pathway, but BLK is an example of a rare variant that is very active in B cells. And, you know, each of these sets of genetic variants, whether rare or common, points us to key mechanisms, key pathways that participate in lupus pathogenesis and really help us to think about how we might very logically target the disease. So there are many therapeutic targets that track to the adaptive immune system in lupus, and I'm by no means mentioning them all here. But like we did thinking about the innate immune system, the type 1 interferon pathway, we can kind of go from upstream to downstream and think about what can be learned and how can we target the signals coming into those T cells as we learn more about which T cell populations are important. And at this point, I'm thinking it's very likely that both T follicular helper cells as well as Th1 cells are very important drivers of B-cell differentiation. I haven't mentioned T regulatory cells, a pathway that could be amplified in lupus therapeutically. But then we can target T-cell, B-cell interaction. Going back to, I hate to say, maybe 25 years ago when my lab studied CD40 ligand and its prolonged and overexpression in lupus T-cells, it became pretty apparent that the CD40 ligand pathway and interaction should represent a very significant therapeutic target. The efforts to inhibit CD40 ligand with antibodies were not successful back then, but I think they may be coming back and represent a very logical target. IL-21 I mentioned, and now I'm mentioning interferon gamma as an additional cytokine target in lupus. But there are direct ways of targeting the B cell that we're all well aware of, and we have anti-BLyS, we have anti-CD20, but there are kinases that are specific to B cells or fairly specific to B cells, such as BTK, that might make a lot of sense as well. So just kind of reprising my message and my theme with regard to how we can think about lupus pathogenesis, but then take those lessons and have ideas for more successfully addressing lupus therapeutically. I think that what we might want to ultimately think about is to target representative targets from each of these pathways. The adaptive immune system, and in that case, I think it would be something related to type 1 interferon, as well as the adaptive immune system, and I think we have many, many options there. Of course, the challenge is drug development doesn't happen, 2 or 3 drugs at a time. We have to test one drug and demonstrate efficacy. But I think we might need to be clever in thinking about how could we take an approved drug, add on a test drug from a different pathway, and see if we can make some headway in gaining insight into really how we can have better therapies for our patients. So I'm going to just very briefly mention the bucket of lupus-associated genetic variants, really just a few to my knowledge at this point, that might impact tissue injury. And it was very nice to see in this review article that some of the well-known genetic lupus-associated genes, FC, one of the SC receptors, ITAM, IRF5, PTPN22 can be thought about with regard to lupus nephritis and kidney damage. Now, of course, those all really are acting at the level of the immune system, not the target organ. But as we learn more about the non-immune components of target organs, with lupus nephritis, I think, being a very important model disease to study, we'll probably get some ideas about what contributions podocytes, the stromal cells, other components that are not immune system components in the target organs might be making to disease. So I apologize to all of the investigators and authors whose work I didn't talk about. It is true that lupus is a complex disease, and we can try to deconvolute it by simplifying our thought process in the message, but it remains a very complex and challenging disease. But here are some of my messages: that analysis of genetic variants conferring increased risk of lupus can identify key molecular pathways that contribute to lupus pathogenesis. Rare genetic variants can give us clues, particularly with regard, it seems, to management, regulation of self-nucleic acids, cell components that might potentially be stimulatory to the immune system. But there are many messages from those more common genetic variants that track to pathways in both the innate and the adaptive immune system that give us insight into the role of type 1 interferon, as well as many of the pathways that drive T and B cell differentiation, how those two cells interact, and then how we can use that information therapeutically. And then I guess my challenge to all of us is to think, can we bring together therapies that target several different pathways, particularly these two that I've identified? And if we look at the results of clinical trials, I think drugs often meet their target. An interferon-targeted drug might reduce the interferon signature, but it's still not demonstrated to be effective in clinical trials. Well, maybe we need to combine it with a partner therapy. And I will stop there. And we might have 1 minute for questions. Do you?
Yeah, well, yes, we have only got 1 or 2 minutes for questions, but I'm pleased that let's start with Q&A number 2 there then, sir.
Thank you.
If you say who you are and where you're from, first of all, that'd be great.
Yeah. Tom Stoll from Switzerland. Thank you for your very interesting talk. You showed nicely how RNA-complaining immune complexes activate interferons. On the other hand, in the disease, we have anti-DNA antibodies. How can we explain this shift from RNA to DNA?
Mm-hmm. Well, it's a question that I think a lot about, and I think that there are some very key differences between the pathways and the B-cell types or forms that produce those two classes of antibodies. I think that those long-lived plasma cells in the bone marrow that Thomas has probably studied a bit are the producers of those RNA-targeted antibodies that are persistent over time. I think more and more there has been the observation from different labs that neutrophils fluctuate in association with disease activity and with anti-DNA antibodies. And I think there's an opportunity to study neutrophils in more detail, their products, and how they might link to anti-DNA antibodies. So, what brings the neutrophils into play? It could well be some of those nucleic acid immune complexes that incorporate RNA. It's been shown that RNA immune complexes drive neutrophils to nettose. So there could be that kind of connection, but I think we need more study of neutrophils.
Thank you.
Sir, yeah, you're the last question, I'm afraid.
Okay, Walid from Dubai. Which part of the immune system, is it the innate or the adaptive immune system that pushes the disease to the severity from the skin to the neuropsychiatric lupus?
There have been studies in skin from Michelle Collenberg demonstrating that one of the type 1 interferons, interferon kappa, is important. There have been studies from Michael Carroll implicating type 1 interferon in microglial activation and potentially CNS lupus. I think the innate immune system is probably very, very important in both of those clinical manifestations. And I really can't speak specifically about the adaptive immune system, but I would point to the innate immune system there. Thank you very much.
Okay, thank you very much indeed. Right. We're moving swiftly on. We have Professor Thomas Dorner from the charity hospital, University Hospital in Berlin, who is down as the Professor of Rheumatology and Hemesthesiology, which is a new specialty for me, but Peggy kindly translated it as the Professor of Clotting, essentially. So he's going to take over more, but to talk about, again, treatments and mechanisms of treatments in systemic lupus.
So, thank you very much, Jonathan, for the introduction. Good morning, dear colleagues. It's my pleasure to provide you with some concepts. I'm promising I'm not going into very much detail in one or the other clinical study, but I'm trying to give you a more or less overview and in terms of concepts. These are my disclosures. If we are this is the agenda. After some introduction, I will focus a little bit on new aspects in lupus nephritis, go then in extra-renal lupus, and then we'll try to develop with you together some concepts for new therapeutic approaches. If we look into lupus, and that's not unique to lupus, we see that the disease activity, but this in particular case, it is linked with type 1 interferon, but also with the plasma cell signature, maybe in kids also with the neutrophil signature. This leads, related to the disease activity, to damage clearly connected to disability, and last but not least, might lead to premature death. in all the correctness, this reference here connects this also to the expenses. The last D is dollars. Very interesting under current conditions. If we look then into lupus, and there are two very nice papers, and the one I picked here is from the Toronto lupus cohort, showing that although we have observed even in lupus patients an increase of the life expectancy, it's still about 20-25 years lower as compared to the general population, and in particular affects females between the age of 19 to 44. The only little good message is, if our lupus patients are arriving at the age of 85, they have the same life expectancy than the general population. But honestly, I have not seen so many patients with lupus at the age of 85 so far. So when we look into lupus, we have observed some failures. With a very few exceptions, I'm going to go into this. Most of these trials either failed superiority, have been terminated prematurely, or for any other reason terminated. This brought us to some news at the end of last year or the beginning of this year that lupus might be in crisis. And one of my tasks is here to convince you that this might be part of the so-called Kuhn cycle. The Kuhn cycle is nothing else that in order to change our behaviors and change paradigms, we need to be fueled of our practice by science. And I think what we see now is that we need to look for further scientific insights in order to improve our practice, in order to arrive at paradigm changes. And that's one of my tasks here, to convince you that we are really on a good way, I think. So, but before we go into this, I think it's also pretty much important if we discuss this on scientific terms and asking the questions, what are the reasons of the recent trial failures? And most of the data I'm showing you is part of a recent publication in Lancet, and I had the privilege to do this, and all my acknowledgements to this colleague with Rich Fury from Northwell in New York. So why did these trials fail? It could either be an inappropriate target, so the drug did not differentiate. It was either an inappropriate trial design, poor choice of the primary outcome. Somehow we have improved, I think, with the more or less establishment of the SRI4. The poor choice of concomitant medications, and very importantly, the co-medication of the steroids. Very often they have been used completely different than what we are doing in our empiric clinical practice. But one of the, I think, largest hurdles or challenges is, and I'm trying to develop this further with the concepts, is that we are facing, and you have heard this already nicely by Peggy Crow, facing a substantial heterogeneity in SLE, what we are not seeing in any of the other rheumatic diseases. And I think probably some of the trials have been inappropriately designed for all comers. Just an example. And this is again a very nice study retrospectively by Murray Urowitz from the Toronto cohort. They segregated their lupus patients according to their clinical courses. And it's very similar, I have to say, what we might see in patients with multiple sclerosis. There's one so-called monophasic group having a flare initially and never reflaring. And those are the patients who might come into remission without any additional need of immunosuppressive therapy. This is about 10% of the lupus population. About 2/3 of the lupus population consists out of a relapsing remitting form. I think this is the most prevalent form. And then there is another form, about 10% in addition, with a persistently active lupus condition or course. And if you put them all together, you see this hybrid here, and maybe this hybrid, what we are seeing in clinical trials, is not representative of all these individual forms of lupus. So when we discuss about heterogeneity, and in addition, you have heard already in terms of the pathogenesis, there's not an exclusive genetic association as in other diseases. For example, the heterozygosity of DR3 and DR15. We see abnormalities in the myeloid, but also in the lymphoid cells, subsets, but very heterogeneous. In terms of the laboratory findings, I will come back later to the ANA, but the titer, the pattern might be different. Some of the patients have anti-DNA antibodies, some never produce those antibodies. There are differences in the hypocomplementemia, and some of the patients, about 2/3, have a type 1 interferon signature, 1/3 has not, and another 2/3 has a plasma cell signature. We discussed already some of the differences, and you know this in terms of the clinical manifestations. Not every patient has the same profile in terms of tissue organ manifestations. The disease course I alluded to, and the complications could be very different. Last but not least, the response to biological and synthetic DMARDs is different, as well as the safety and tolerability. So we are facing a number of challenges in this very heterogeneous disease, but there are some possibilities to approach this. So the heterogeneous disease has a substantial risk of damage accrual and premature death. We see disturbances of the innate and adaptive immunity, but what we see, and we might take this as a lesson, most of the patients who have really clinical active immune-dependent disease respond to pleiotropic glucocorticoids, which on the other hand have the burden of enhancing the damage accrual. And one of the challenges in lupus is really to reduce the corticosteroids and at the same time controlling the disease. That's a challenge, for example, we have never seen in RA. They are just using now trial designs in order to demonstrate that they are able, using biological therapy, to reduce the daily usage of corticosteroids. So how can we approach this to improve the response and at the same time minimize the glucocorticoids? On the one hand, one can use or approach the globally activated immune system by a so-called multi-target therapy, covering different pathways simultaneously or subsequently. That's one possibility. I will try to give you some examples. Or taking a completely different approach, not suppressing the immune system, rather using immunomodulatory concepts to self-reconstitute the immune system to better control the disease activity. So what is new in terms of lupus nephritis? I will go into some of the aspects, but before we go into this, there are still 20 to 25% of the patients who do not have sustained complete or partial remission after half or 1 year. End-stage renal disease is still a challenge. About 10% within 10 to 20 years in different cohorts reach end-stage renal disease based on lupus nephritis. 85% of the patients have still continuously active disease and flares over 1 year of observation. And even among the non-responders, flares and overall deterioration are not unusual, and still they require immunosuppressive and long-term glucocorticoid therapy. So the goals in lupus nephritis, this is based on the ACR 2012 and the Eular 2012 recommendations, which will be updated pretty soon, to achieve during induction improvement, maintain this in the maintenance phase, and simultaneously prevent organ tissue damage and improve the quality of life in patients. I'm happy here to share with you the data that have been recently obtained in terms of a positive predictive value, and the main parameter is reaching proteinuria of either 0.7 gram per day after 1 year of induction. That's the result of the MAINTAIN trial. Very similar, Maria de Lara from a US trial showed this for 0.8 gram per day. These are data here from Frédéric Cousseau from Belgium. Has a positive predictive value of 94%. If the patients after 1 year achieve this, then of the subsequent 7 years, those are the ones who are achieving complete and stable remission. It has a very low negative predictive value, but this positive predictive value has been confirmed by the US trial. George Basias from Greece was so nice to share with me part of the upcoming updated Eular recommendations for treating renal involvement in lupus. And they come up now with treatment targets or treatment goals. And the treatment goals are the reduction of proteinuria. Once again, this is the key parameter. And they come up with a recommendation at 3 months, a reduction of proteinuria by 25%, at 6 months, 50%, and by 12 months reaching the goal of 0.5 to 0.7 gram per day. And if you want to consider the patients as complete responders, it needs to be optimized in terms of the renal function. At the same time, again, they are asking to minimize the glucocorticoids at the maximum of 5 milligram per day. So this is something new, changes some paradigms in treating lupus nephritis, because those colleagues are now setting new goals in the 2019 update. So what is current practice? On the one hand, we discussed this last year. There was a proposal by colleagues from immunopathology to change the histology classification or the immune classification. There have been now the new updates also by Brett Rovin, by a large nephrology, rheumatology community. They are still recommending to go on with the ISN RPS 2003 classification. It's further recommended, but one should in addition consider the tubulo-interstitial involvement. This is the area where the T and B cells are interacting. In addition, activity chronicity indices, and very importantly also paying attention to thrombotic and vascular lesions associated with coexistent antiphospholipid syndrome. They also recommend the use of hydroxychloroquine at a dosage of up to 5 milligram per kilogram. I will come back later to this point, because it has been shown, on the one hand, antimalarials are delaying the end-stage renal disease, and they are also able to triple the effects of the use of MMF. So nothing has so much changed. If you go into the classical subtypes, in particular, the main area is the class 3, class 4. For the induction is still recommended glucocorticoids with urocyclophosphamide, or glucocorticoids combined with MMF or mycophenolate acid. Maintenance recommendation is either glucocorticoids with MMF. In some of the meta-analysis, this is slightly superior, at least numerically, compared to a maintenance therapy with glucocorticoids combined with azathioprine at the dosage of 2 milligram per kilogram, and the low-dose prednisolone between 2.5 to 5 milligram. Refractory cases, this is now one of the challenges, because some of the patients are really responding very well to this induction maintenance protocol. The refractory cases, we have recommendations by the ACR and Eular to use in those patients rituximab. About 1 to 2% of the patients are receiving this, or calcineurin inhibitors. There has been a press release 3 days ago, and I think this is somehow promising again and consistent with the experiences we have in clinical practice, in contrast to the clinical trial data. A second-generation CD20 antibody, obinutuzumab, Gavtera. There was a press release that the Nobility trial met its primary endpoint, where the antibody has been used in combination with MMF and corticosteroids. A concept of combination, I think, very clearly also fulfilling multi-target therapy concepts. And they also met key secondary endpoints. It's just the press release available. We will see the data pretty soon, I think, during this year. But the other opportunity or the new insights we got over the last year is the use of calcineurin inhibitors. Although most of the studies have been done in Asia, we have seen in the cyclophalone study that cyclosporin A was not superior to cyclophosphamide if patients with class 3 and 4 have been studied and followed over 7.5 years. And in a retrospective analysis, cyclosporin A and MMF showed a response in about 70% of patients. In Asia, one study compared directly tacrolimus with MMF in 150 patients over altogether 60 weeks. And if you look here, the complete and partial responders were quite comparable, but non-responders were only 11% under tacrolimus compared to 20% under MMF. At the last San Francisco World Lupus Congress, Dr. Mock showed data after 10 years, and he could demonstrate when the patients then were continued on azathioprine, the outcome was quite comparable between both groups. So it looks like, at least in Asian patients, as a good alternative for induction and a little bit prolonged induction. The concept of multi-target therapy comes basically from our colleagues in nephrology, using some of these concepts already in patients with renal transplants. And I think it's nothing else what we are using in terms of antihypertensive and anti-infective therapies. We are combining drugs in order to cover multiple pathways. And what they have done here, after the initial trial comparing tacrolimus with MMF, they compared the combination of tacrolimus with MMF to cyclophosphamide in the induction period. And what, as you can see here, MTT responders, complete responders was 46 compared to 26% under cyclophosphamide, so doubling the response. Interestingly enough, when those patients after cyclophosphamide then were treated with azathioprine and MTT was continued for another 18 months, the response rates were quite comparable. There were only differences in the adverse events, higher under azathioprine, as well as withdrawal was higher under azathioprine. It's still recommended for induction, but it's apparently not so good evaluated and cannot be recommended for prolonged maintenance, the use of calcineurin inhibitors. There is a new calcineurin inhibitor called voclosporin. It's basically a structural modification of one functional amino acid of cyclosporin A. It might have possibly an enhanced potency compared to cyclosporin A, shows less variability in terms of the plasma concentration, and might have potential advantages in terms of the hyperlipidemia and hyperglycemia induction. This has been studied in a phase 2b, published at the end of last year by first author Brett Rovin, and they looked and following MTT principles for the primary outcome, which was a urine protein creatinine ratio of maximum 0.5, normal or stable renal function. Corticosteroid usage was only allowed maximum 10 milligram after a very strict reduction between week 16 to week 24. The primary endpoint was at week 24, and there was no allowance for rescue medication. Altogether, two different dosages, a low dose and a high dose, was compared to a placebo group. And as we observe very often, the low dose group was more efficacious as compared to the high dose group. You see this here for the primary outcome. Only 19% under placebo were considered as responders in this trial, 27% for the high dose voclosporin, roughly 33% for the low dose. Over the subsequent half year, the response rate were further increased, but now this compound is in phase 3. There were slightly higher death rates in the low dose group, but in the overall adverse events rate, it was quite comparable, but the deaths were distributed. There was not a particular aggregation of certain causes of death. So what do we view, or what's new in terms of lupus nephritis in 2019? It has been now introduced to treat to target principles based on proteinuria within 1 year. There is still the consideration of lupus nephritis classification in terms of the histology as the gold standard of the ISN-RPS 2003, with the additional consideration of subtypes, podocytopathy, tubulointerstitial lesions, and the thrombotic microangiopathy related to antiphospholipid syndrome. It's recommended to save or to reduce glucocorticoids to the minimal dose needed, use of hydroxychloroquine or antimalarials, optimal nephroprotection. For the induction and maintenance, there is still the possibility for the induction to use Urolupus IV cyclophosphamide or MMF, followed by long-term MMF or azathioprine, while new data indicate the value of calcineurin inhibitors, at least for the induction period. Calcineurin inhibitors have value in combination with MMF for refractory lupus nephritis, have also value in class 5, and they are safe in pregnancy. There are new data on the multi-target therapy, including calcineurin inhibitors such as voclosporin, which is in clinical development, but need further evaluation in the induction and maintenance period. Higher infection rates overall have been seen under the combination of tacrolimus and MFS, as well as voclosporin in combination with MMF. So what's new in the management of extra-renal lupus? I will go in a few aspects. First of all, in 2019, we see now the revised lupus classification that will be soon published in the Annals of Rheumatic Diseases and simultaneously in Arthritis Rheumatology. This is a combined project between the ACR and Eular, and I was privileged to be part of this. It was also outside of ACR and Eular, including colleagues from Latin America, from Asian countries, etc. We went really out to make classifications of truly autoimmune systemic lupus, because there was a strong belief maybe the classification is not appropriately enough to concentrate patients suffering from lupus and that are eligible for clinical trials. We wanted to exclude lupus mimicers, and Marta Mosca from Pisa has done a great job in this. And we wanted, very similar like in systemic sclerosis and RA, giving different organ manifestations a different weight, because this is how we also approach lupus in clinical practice. And we want to have the classification suitable for early classification, but also allowing consideration of pediatric patients. And therefore we had also some pediatrician in the group. This was a group of altogether 198 authors. And you see this is slightly higher as the previous proposals of classifications. It did not only take 198 authors, it also took the very excellent software 1000 Minds. This is here a picture from our 1.5-day meeting in Washington, D.C., right after the ACR, where in particular Martin Ahringer and Sindhu Johnson, as representatives from the Eular and ACR side, did a great job over the last 4 to 5 years. And as you might identify, this was very hard work. It needed a lot of coffee, which is a recurring theme I identified when I was preparing this talk. So, what I want to at the end convince you, and when Martin Ahringer went out for this classification, he also said very often, I still have it in my mind, we want to have a classification system which is easy to understand, easy for practice, and also easy to teach to students, which was very often a problem to us. And I will try to convince you, when I was preparing this talk, it takes 10 to classify lupus in 2010. Why does it take 10? But before I go into this, maybe we park for a minute this. These are the 2019 Eular ACR classification criteria. It starts with entry criteria and an ANA, positive ANA of at least 1 to 80. And you need to read carefully the text, because this 1 to 80 has a footnote, because we get very often the question, 1 to 80 we have very often, it's almost each of my patients. It's above your local cutoff. This is the very important footnote. Yeah? And then we have altogether 10 different domains, from nephritis, subdifferentiation of ANA of autoantibodies, serositis, certain skin manifestations, CNS manifestations, arthritis is in a separate domain. Hematology domains are mainly immune cytopenias, hypocomplementemia with C3 and C4, unexplained fever. This is absolutely new. This is new because this came up at the Washington, D.C. meeting as a good identifier of early lupus, otherwise unexplained fever, and the presence of anti-cardiolipin, anti-beta-2 glycoprotein antibodies. And now I resolve the question about it takes 10. These are 10 different domains, and you need to have at least 10 different points. And in order to make it very easy, for students, take your 2 hands. If you have 10 fingers, you can easily come with the rule of 10. This has been validated in the last few months compared to the prior lupus classification, and in terms of the sensitivity, you see it's around the sensitivity values of the SLE 2012, and it's in terms of the specificity exactly matching the specificity of the ACR 1997. So, and therefore, we think we should now be able, in terms of the classification, completely independent. You are still free to diagnose lupus, but if we want to enroll patients into lupus trials, I think this can be considered as an improvement. So, treat to target in lupus. Over the last 4 to 5 years, we have seen initially by Eric Morant from Australia and colleagues from the Asian Pacific region, an operational proposal for lupus low disease activity. And it mainly covers 2 domains, therapeutic and clinical activity. Mainly achieving low lupus disease activity requires a SLEDA of a maximum of 4, no major organ involvement, no new features of activity, a PGA of maximum 1, and it is allowed prednisolone maximum 7.5 milligram per day, anti-malarials, and allowed or approved immunosuppressives and biologics. Similar, like Professor Doria from Padua, then Ronald van Voldenhoven, they almost went out together or simultaneously to go for operational definitions of remission. And remission in lupus, and this is the DORIS remission operational definition by Ronald van Voldenhoven, requires a SLEDA of a maximum lower than 2, clinical SLEDA is 0, clinical ECLAMP 0, or BILAC only D and E, PGA 0.5. Allowed are anti-malarials and prednisolone only to a maximum of 5 milligram. What is still subject of further research is the duration of this remission status. But it's now up to research to use these operational definitions for clinical trials as outcome. There are already trials ongoing using low disease activity, and how make they a difference in terms of the damage accrual over time? Does it make a difference, low disease activity versus remission? But I'm very convinced we will see upcoming new data on this. Overarching principles in treating extra-renal lupus, it's quite obvious. Glucocorticoids, lowest possible dose and for the shortest period of time. Anti-malarials are strongly recommended, and DMARD therapy is indicated for patients with persistently active and/or life-threatening disease. And I'm not going into the details because this is part of a lot of papers, treatment of comorbidities. In the last year, actually, there came a number of treatment recommendations available, one by the Canadian Society or Rheumatology Association, by the Latin American, the Cladel group, as well as there will be an update for the 2019 Eular recommendations. This will be presented on Saturday morning at 9 o'clock in the recommendation session. But also the British Society came up with guidelines, and I think they are pretty close to clinical practice, and therefore we use this as a kind of scaffold where we try together with Rich Fury to come up with a kind of merged recommendations of or treatment algorithms for extra-renal lupus. If you segregate lupus in mild, moderate and severe, for example using the SLEDA up to 6 to 12 and higher than 12, and make a distinction between the induction medications as well as the maintenance medications. We usually start in the patients with mild for induction with NSAIDs or COX-SIBs and glucocorticoids maximum of 20 milligram or local glucocorticoids. In all of the patients, anti-malarials of a dosage maximum 5 milligram per kg should be applied if patients are tolerating this. In the mild, for maintenance, low-dose glucocorticoids, maximum 7.5 milligram, or the use of local glucocorticoids, or methotrexate with 10 milligram per week, so a lower dose as compared to the others you might see. In the moderately active, we are using higher dosages of glucocorticoids or methylprednisolone, a maximum of 0.5 milligram per kg, azathioprine 2 to 3 milligram, or methotrexate 10 to 25 milligram per week. These are higher dosages in patients with severely active lupus, including intravenous methylprednisolone, higher dosages of azathioprine 2 to 3 milligram, MMF 2 to 3 gram per day, or the NIH cyclophosphamide, 750 milligram per infusion. Maintenance, quite comparable. The maximum 7.5 milligram per day prednisolone, azathioprine 50 to 100, methotrexate 10 milligram per week, or MMF just 1 gram for maintenance. If the patients are not properly responding to this, one can add or should add belimumab in the active patients, or there is the possibility also, according to the recommendations, using rituximab or any of the experimental therapies. 2 words to 2 drugs, or 2 points, or few points. One is hydroxychloroquine, the other is belimumab. If one goes into the BSR recommendations, the antimalarials have a grade A recommendation, and the overall level of evidence is 1 and 2 plus. They are still coming with 6.5 milligram per kilogram recommendation. According to the recent ophthalmology concerns, one should rather go with 5 milligram per kg. Belimumab has a B level grade or B grade of recommendation, but a 1 plus in terms of the overall level of evidence. We know from the antimalarials that they are really able to prevent damage. You can further increase the reduction of damage accrual by the addition of aspirin, at least based on retrospective analysis, not rigor clinical studies. If we talk about hydroxychloroquine, as I was mentioning, there are a lot of national, international recommendations. There are proposed risk factors for the use of hydroxychloroquine and the main risk of the development of retinopathy. This is higher the risk if daily dosages of 5 milligram per kilogram actual body weight is used, prolonged use beyond 10 to 25 years, or a high cumulative dose of above 600 to 1,000 gram, chronic kidney disease, stage 3 to 5, and combined use of tamoxifen, which is apparently enhancing the toxicity if tamoxifen is used simultaneously for more than 6 months. So we are somehow in a kind of dilemma. We know on the one hand, our patients are not adhering to this therapy as good as we believe. On the other hand, we have not a clear dose-response relationship in the empiric use of hydroxychloroquine and antimalarials, and there is a lot of discussion and scientific research going on to fill this gap. But for the moment, following the ophthalmology recommendations, we should rather use 5 milligram per kilogram actual body weight hydroxychloroquine. So, a few words to belimumab. That's the drug that met in 4 independent trials the primary endpoint, SRI-4, in the BLISS 52, 76, subcutaneous, and an Asian study. We have been able to identify a responder group with active disease, SLEDAI higher than 10, positive anti-DNA. Anti-DNAs are part of the ANAs, reduced complement, and steroid use higher than 10 milligram per day. For me, this is really the classical core lupus group, and somehow if one would use the classification system of 2019, maybe we would have enhanced the responder profile in these trials, but that's just a personal suggestion. I was very convinced last year, after we have seen data from an Italian multi-center cohort, that belimumab is able to reduce damage. This was led by Professor Andrea Doria, but also Ronald von Vollenhoven showed this for the long-term extension study, and Murray Urowitz did a very nice study, and this is published in the Annals this year. He compared a continuation of standard of care to patients who received belimumab, and he did this very nicely with a propensity match analysis. And what you can see here, after 76 weeks, this starts already very early on, that belimumab is able to prevent damage. And I'm really looking forward to see the data, whether this is also able to prevent premature death in the lupus population. So it took some time also for me, but it's becoming more and more evident that belimumab has its value in the treatment arsenal of lupus. So what are the new treatment concepts in lupus? One of the ideas is that maybe the single, and this is consistent with the pathways that Peggy Crow alluded to before, single target approaches like simply treating IL-6 receptor, using CD22 or CTLA4 Ig is maybe too restricted given the multitude of active pathways that are active in heterogeneous lupus. And possibilities to get out of this challenge is using strategies that cover multi-targeting therapy, either in sequential or simultaneous combination, or drugs affecting multiple pathways. One of the classical is glucocorticoids, but we know the burden of side effects is unacceptable. Or alternatively, going with immunomodulatory concepts, and I'm a great fan of these immunomodulatory concepts. So starting with the sequential targeting, one of the first was Onno Tang from the University in Leiden, who went on in patients with severe lupus nephritis. These were 2 cases they published first here with severe proteinuria, and they gave those patients initially rituximab, and subsequently this therapy was followed by belimumab in order to suppress the compensatory increase of BLyS after B-cell depletion. And they have seen, as you can see here, the black line is the proteinuria, really a substantial reduction of the proteinuria. This has been followed by a number of other case reports and led then also to the so-called uncontrolled study Symbiose in altogether 14 patients, again at the University of Leiden. About 11 had lupus nephritis. They have reported a substantial decrease of SLE from 18 to 2. And in the patients with lupus nephritis, they have observed 4 complete responders. There is now an ongoing phase 3 to evaluate this. This has not been at least semi-confirmed in a different approach by our colleagues in the US, by David Wofsy and Betty Diamond, who led the Calibrate study. They combined over 48 weeks rituximab in combination with cyclophosphamide, and the same rituximab cyclophosphamide then combined with belimumab in altogether 43 patients. As you see here, for the complete partial non-responders and the did not finish patients, there was no significant difference, in particular no significant difference in the rate of renal responses at 1 year or week 48. An alternative is using a different antibody that we have used in Sjögren's patients, directed against membrane-bound BLyS, which simultaneously leads to a substantial depletion of B cells. That's ianalumab, which might be an alternative if one goes to sufficient B cell depletion and simultaneously BLyS inhibition. It's now, as I was mentioning, in the BLyS Belief study under further investigation, but also at the University College of London with Michael Ehrenstein and David Eisenberg in the BEAT Plus, this combination of rituximab and belimumab in the sequence. So you have heard already and seen this by Peggy Crow, targeting the interferon pathway. And among possibilities to block the production by targeting, for example, plasmacytoid dendritic cells. One possibility is to use an antibody against the type 1 interferon receptor, which is able to block not only the effects of interferon alpha, but all the other type 1 interferons. Another possibility is using vaccination strategies with a so-called interferon alpha kinoid. That has been presented, the first data by Frederic Cousseau at the Lupus Congress in San Francisco. So it has still some potency of combined targeting because we are blocking not only interferon alpha, and the phase 2 studies the phase 2 study has been presented and reported by Rich Fury and co-authors using the antibody anifrolumab, and they compared a low dose anifrolumab in addition to standard of care to a high dose to a placebo group, and the primary endpoint was after half year, 169 days, with some secondary endpoints after 1 year. They used a very strict corticosteroid tapering effect in order to really make sure what they are observing at day 169 is an effect that accounts for the drug, and it's not influenced, at least partially, by the use of glucocorticoids. Interestingly enough, you see this here, when they are looked in the overall population, there was the lower dose more efficacious as compared to the higher dose, a good segregation from the placebo, but this was even further enriched, the treatment effect, when they looked only in the interferon high patients. These effects were further enhanced in the subsequent period of the second half year, but the differentiation was not seen for the interferon low group, at least at the primary endpoint here, and also the differences were not so convincing after 1 year. It's still under further investigation, although the TULIP-1 trial, as one of the first phase 3 trials, have been reported at the end of August 2018 that it has not reached the primary endpoint, but we are still waiting for the second, the TULIP-2 data. Another possibility, and you have seen this also already from the concept by Peggy Crow, is using ustekinumab. Published last year in The Lancet, the lead author is Ronald van Vollenhoven. When we are blocking IL-12 and 23 by blocking the P40 chain, and we are very well aware about this antibody that is used, ustekinumab, in a number of diseases already approved, including psoriatic arthritis, we are blocking Th1, cytotoxic T cells, as well as Th17 cells. All of them are believed to be intimately involved in the immune pathogenesis of lupus. And this study compared one dosage with an initial IV loading dose over half year, 24 weeks, and the primary endpoint was SRI-4. And then the patients in a 2-to-1 randomization, the placebo patients were then continued with ustekinumab for the subsequent treatment period. Again, interestingly enough, and a lot of people still share this surprise, there was a treatment difference of 29%, and a significant difference if you go for look for the SRI-4 response as the primary outcome at week 24 between the ustekinumab-treated lupus patients as compared to the placebo patients. And the effects were seen for the arthritis or joint components as well as for the skin components. Another trial looking for MTT concepts, also published last year in The Lancet, and the lead author is Dan Wallace, was using baricitinib in patients with lupus, again in a phase 2 trial. When we are blocking JAK1 and JAK2 using baricitinib, we are able to inhibit or target type 1 interferon, type 2 interferon, IL-12, 23, and IL-6. Again, cytokines that are implicated in the pathogenesis of lupus. This has been done in comparison to placebo, where 105 patients were enrolled, and using the approved dosages, at least for RA, outside the US in 2 milligram per day or 4 milligram per day, over again 24 weeks. And the data are here. The primary outcome was the resolution of skin and joint manifestations at week 24 using the SLEDAI-2K. And the differentiation for the 4 milligram to the placebo was of significance already at week 20, but also at the primary endpoint at week 24. There was still a dose-response curve with the 2 milligram, but it did not significantly differentiate to placebo. If you want to see this for the SRI-4, you see here 64 responders for the SRI-4 at week 24, and the treatment difference to placebo is roughly 17%. This is continued like ustekinumab now in phase 3 trials. Other potential possibilities to go with multi-target therapy is using BTK inhibitors, SYK inhibitors, interfering with Ikaros, Aiolos as transcription factors, or different JAK inhibitors. All of them have a multitude of effects intracellularly and might have the promise really to target very important pathways that are effective in systemic lupus. So my last point is rebalancing the immune system. And one of the possibilities is to allow the immune system a little bit of reconstitution or self-reconstitution. We are giving the patients low-dose IL-2, and we turn around a little bit our pathogenesis scheme. Yes, make a picture from this. It's on purpose the other way around. So the first proof in concept was done by Jens Humrich and Gabi Riemekasten at our institution. They studied this in 12 patients using a low-dose IL-2 that has an approval for bladder cancer. And as you can see, the SLE in the patients went down. Altogether, 2/3 of the patients were responders out of these 12. And they could show a very stable Treg induction, but it was not very lasting. It was really dependent on the infusion, so no lasting Treg induction. But they could demonstrate a reduction, a substantial reduction in steroids, no changes in the autoantibodies or complement levels. This was then confirmed by a Chinese study in altogether using a different low-dose IL-2 in altogether 38 patients. They also demonstrated using the SRI4 responses. The SLE score went down, and again they could show reduction in the daily corticosteroid usage. What they also showed, different to our study, changes in the autoantibody titers and changes in the complement. At the last conference in San Francisco at the beginning of April this year, they could demonstrate report the first data on the randomized control trial with low-dose IL-2 in altogether 60 patients with significant improvements in the SRI4, SLE, and the induction of remission. The adverse events were mainly restricted to injection site reaction. Publication is pending. This was an oral presentation. So what I wanted to address or discuss with you, paradigm changes in extra-renal lupus in 2019. I think some changes come with the possibility with the new Eular ACR classification criteria and the possibility for the operational definitions of low disease activity and remission, requiring the minimization of glucocorticoids, what we are doing in clinical practice. In order to address the multiple phases of lupus, either we go on, and you are more invited to do this, to find the holy grail in lupus, or going with an oligo or one target approach, when we are identifying the keynote of immune activation, or we go rather with a multi-target MTT approach, either within, I showed you some example, the sequence, rituximab, belimumab, or simultaneous blockade of certain very important pathways. For examples are ustekinumab or baricitinib, or improving immune competence by using low-dose IL-2. Before we might be able to enter the era of personalized medicine, when we can stratify our patients based on their endotype and phenotype on different levels, and then using a kind of patient-tailored therapeutic approach, which might be more successful than the broader coverage for all comers. And with this, I would like really to thank all my colleagues, and some of them I have mentioned, and I had the privilege to work for a long time, very long time, in a very ambitious institution. Thank you so much.
Right, great. Well, that I really do believe was a masterclass in the subject. I don't know, obviously everyone wants to go and have their coffee and some sort of sweet refreshment, but if anyone has any burning questions, we do have a couple. We'll take a couple of those now, but I will not go on for much longer. Sir, why don't you go ahead?
Yes, this is Osama Haji from Egypt. Do you think it's wise enough to treat the patient with plaquenil with undifferentiated systemic connective tissue disease? It means that the patient has positive NA with non-specific early manifestation.
I think the use of plaquenil is not restricted to lupus. There are some preliminary or small study data out that plaquenil might be able to prevent the development of full-blown disease. As long as there are no contraindications, I think it's one of the treatment possibilities.
Thank you.
There we have a question number 2 there. We'll do.
Ahmed from Lahore, Pakistan. Brilliant talks, excellent review. How far are we from identifying patients so that we can treat them according to their antibody profile or, their interferon signature? How far are we from that? Because we're still groping in the dark for these $1 million therapies, which obviously we cannot use in the world mostly, which is underdeveloped.
Best case scenario tomorrow, worst case scenario in 10 years.
Oh, okay. Thank you so much.
Fantastic. Look, well, okay, very short. We'll have one more question. Can we do that from question number 3?
I'm Sumaira Farman from Pakistan. My question is that in the recommendations for extra-renal treatment, I was wondering why are we still going with a higher dose of prednisone and such a low dose of methotrexate or MMF rather than staying with a higher dose of methotrexate and MMF and going down on prednisone?
Actually, you are raising a good point. This was a kind of attempt to make some general recommendations. For the individual patients, I think you need to adjust the dosages appropriately. If the patients are much better and stable with 15, not with 10 milligram, that's fine, as long as you are able to reduce the corticosteroids to a maximum of 7.5 milligram per day.
Thank you. That's my point.
Okay, look, I'm going to stop there. I think we've stressed our speakers enough. Thank you very much indeed once again for attending, and we'll close there.